First, I would like to welcome all the delegates from everywhere in Africa and Cairo. Wish them a very successful international meeting. This is my disclosure. HCC is the major health problem actually in Africa, and the major cause of premature death in Africa among Africans is chronic hepatitis B, because it is very early transmitted during motherhood. The risk factors are well known and avoidable in most of the cases. And as been mentioned by Professor Edith, that the incidence is very high and the mortality is almost equal the incidence. So this represents how fatal is this disease. The distribution of the risk factors is different from region to region, and also the incidence is very high in North Africa due to Egypt, and with almost the same mortality rate. Comes next is Western Africa with a very high mortality rate as well. Depending on the region, liver cancer is thought to result from the exposure of many risk factors. Risk factors vary from one place to the another, depending on habits, lifestyle, food consumption, and surrounding infection. Prevention of liver cancer requires knowledge of these risk factors and ways to avoid them. As you know, liver cancer is a preventable disease. So the risk factors, as been mentioned, is the major risk factors in Africa is hepatitis B, represents from 50 to up to 80%, genotype C. Comes next hepatitis C virus with 10 to 25%, Aflatoxin in sub-Saharan Africa, dietary iron overload. All these are major risk factors. Another risk factors like alcohol consumption, obesity, and NASH, and diabetes are also an important co-risk factors. As mentioned, there is a liver cancer consortium and reported important knowledge about HCC. Hepatitis B, as mentioned, is the main cause. Over 50 to 60% in sub-Saharan Africa are hepatitis surface antigen positive. Another 20 to up to 50% have previous chronic hepatitis B or occult B infection. 43% hepatitis B-related HCC developed in adults younger than 40%. So this represents how endemic and how the risk factors are present enormously in some regions of Africa. Hepatitis C is important as well in North Africa because of Egypt, and C-related cases occurred in a higher after young age, after 50, and the peak age from 57 to up to 62%, 62 in age. The Liver Consortium, as mentioned, contains 9 countries, and I'm proud that our center representing Africa in this consortium, 9 countries with 28 tertiary centers, up to near 3,000 patients. Egypt represents more than 1,000 cases versus 9,000 in sub-Saharan African countries. And these are important data, as been mentioned before. The age is higher versus in sub-Saharan African. Also, the etiology is C-related in Egypt in up to 85% of the cases versus, on the other hand, in sub-Saharan Africans, hepatitis B in 55% of the cases. And the mean age, C-related HCC is 58, and B-related HCC is very young, it's 42. When we back to the guidelines, the surveillance of HCC, high rate of HCC in certain risk group makes surveillance is cost-effective route in reducing mortality. And this influenced by the incidence of HCC in the target population, the availability of efficient diagnostic tests at an acceptable cost, which is a very important point, and the availability and effectiveness of the treatment. And I think all these criteria is matching very well successfully among HCC cases in Africa. So surveillance is recommended in specific target population in our continent, in child A or B cirrhosis, C if as a bridge for liver transplantation, and the interval should be directed by the rate of the tumor growth and the tumor incidence in the target population. It's about 6-month interval is recommended as a cost-effective. When we look to the surveillance between East and West, there is no big difference. However, in some guidelines in Western, they recommend liver ultrasound plus minus alpha-fetoprotein. In Eastern, like in Japanese, they insist to have an alpha-fetoprotein, this gamma carboxyprothrombin, as well as triphasic CT or MRI. Also, they put, in some cases, a super high risk persons, which is not mentioned in our regular guidelines, and in this case, they prefer to have a 3 to 4 month interval of follow-up. The prevention, which is a crucial point in hepatocellular carcinoma in our continent in Africa, and the primary prevention can be achieved with the universal vaccination of hepatitis B, of course, and the prevention of progression from cirrhosis to HCC by the antiviral treatment and adequate health lifestyle measures. And according to the WHO, we have 3 steps of prevention: primary, secondary, and tertiary prevention. And by the primary prevention, we have to prevent the infection with hepatitis B and C, aflatoxin exposure, and avoid dietary iron overload. For the secondary prevention, we have to give the proper antiviral treatment and sometimes anti-fibrosis and so on, and metabolic disease manipulation and so on. Also, screening for HCC is an important point in the steps of secondary prevention. In the tertiary prevention, we have to prevent the recurrence and improve overall survival by some measures. When we look to the HCC surveillance program in Africa versus other countries and other continents, we can see in this figure that Africa is having there is a very big gap between African surveillance programs and in any other part of the world, and of course this will reflect on a very poor survival. So the prevention strategy in Africa should sustainable development goals, WHO strategies for the non-communicable disease and viral hepatitis. The primary prevention is the elimination of the viral hepatitis, mass treatment of B and C, hepatitis B immunization, safe injection, avoid parenteral treatment, decrease aflatoxin exposure, reducing alcohol and tobacco consumption, control diabetes and obesity, and community and patients' education, which is, I think it's a very crucial point for the risk factors of hepatitis B, aflatoxin exposure, and health lifestyle option. For the hepatitis C, for example, we have 3 main points for the prevention, which is prevention of infection and the impact, how mass treatment and what is the impact of treatment, proper treatment on the incidence of HCC. When we look to the axis of hepatitis C therapy among different areas in the world, we can see that here in North Africa and Middle East is a satisfactory percentage, 1.5%, versus in North America, which is 7%. And here is other parts of Africa with a negative axis, and of course this will have a negative and bad prognosis for the HCC. POLARIS Observatory project is a very important project. This observatory project is an initiative of non-profit CDA Foundation, provides epidemiological data, modeling tools, training, and decisions analysis to support elimination of hepatitis B and C globally by 2030, offers the most up-to-date estimate for the hepatitis C virus, hepatitis B, disease burden, economic impact, and offers strategies for elimination of each virus along with financing options. And we can see that in the green is the countries on the right track, and Egypt is on the right track, and unfortunately other parts of Africa is still have a delay in this issue regards elimination of hepatitis C virus. What is the impact? Of course, the impact of patients got a sustained virological response have a dramatic reduction of the survival and dramatic reduction of the evolution of hepatocellular carcinoma in the literature all over. And here is the success of the program in Egypt, which has been mentioned globally, worldwide. More than 2.5 million has been cured in Egypt, and of course this will have a very positive impact in the coming years, and the dramatic decrease of the decompensated cirrhosis cases and the dramatic evolution and incidence of hepatocellular carcinoma. What about hepatitis B virus? Of course, hepatitis B virus vaccination is an important point among infant vaccination is very crucial, and according to WHO UNICEF estimate of the third dose of hepatitis B vaccine coverage from 19 to 2015, global coverage is up to 84%, and the African region is 77%. And here is the global coverage of hepatitis B vaccine birth dose, and you can see from the this is just few countries in Africa is having the birth dose, and other countries are still deficient. And of course, this is the impact of hepatitis vaccination, and we have a wonderful experience among Taiwanese with a dramatic decrease of HCC incidence per 100,000 persons per year, a decrease from 92.92 in unvaccinated to just 0.23 in vaccinated cohorts. Of course, in the perinatal infection transmission, which one of the major risk factors of hepatitis B infection in Africa, and of course increase the risk of HCC, and here is a systemic review of the earlier age of infection and associated with increased probability of HCC in the coming years. Also, what is the impact of hepatitis B treatment? Of course, hepatitis B treatment in cirrhotic versus non-cirrhotic dramatically decrease the incidence of hepatocellular carcinoma, and here is a nice research, published nice research. For the hepatitis treatment, also there is a POLARIS observatory program, which shows also that more than 150,000 diagnosed, and just 27% eligible for treatment, and just less than 1% access therapy, and the target is 1 million by 22. And this shows also a lot of deficient countries in Africa that lack of hepatitis B treatment. What is the PROLIFICA project? It's the prevention of liver fibrosis and cancer in Africa, established in 2011, in three West African countries, Senegal, the Gambia, and Nigeria. And this is one five-year translation research project funded by the European Union framework. And the aim of this project is to reduce the incidence of hepatitis B-related HCC in West Africa, and consists of two platforms: the West African treatment cohort for hepatitis B virus and the hepatocellular carcinoma case control study. Some data coming up from this project: validation of 3 point of care rapid diagnostic test, demonstrated the large-scale test and treat hepatitis B program are feasible and cost-effective in endemic countries such as in sub-Saharan Africa, and validated a new biomarker, easy and cheap biomarker, having a very high sensitivity and specificity for liver cancer, discriminating hepatocellular carcinoma from cirrhosis. So it's a very promising project. Aflatoxin, as you know, is one of the important risk factors in Africa, in 40% in Africa versus other continent, cause mutation of P53 gene, aflatoxin B1, and hepatitis B having a synergistic effect, of course, increases the risk rate, and of course, decreased alpha-fetoprotein exposure below detectable limit will, of course, decrease HCC evolution in general population by up to 19%, and in hepatitis surface antigen population by up to 29%. The prevention strategy should be in 3 different ways: chemoprevention, food regulations, and dietary change. And in food regulations, it could be a pre-harvest or post-harvest. What we need still in Africa? Still, hepatocellular carcinoma, of course, is a preventable disease. So primary prevention strategy remains the most important, with a public health approach on risky behaviors, like immunization of hepatitis B at birth is critical and crucial, but remains poorly implemented in Africa. HCC is curable, could be curable, so we have to establish a simple program for early detection that will improve over the overall survival, implementation of a screen and treat for hepatitis B and C at a low cost, develop adaptable resource-sensitive HCC guidelines, which I believe it's one of our needs, our crucial need in our continent, to have our own guidelines according to our risk factors and according to our resources. Develop center of excellence among African countries to improve the diagnosis and curative treatment and management, treating, training, and also to carry some clinical trials. And of course, we have to have an effective fight against aflatoxin. And thank you very much.